Hey everybody, welcome back to another video in our series on cooling for HIE. This week we have Dr. Mike Weiss, who's going to present to you about all the secrets about reading MRI. MRI is one of those tools that we love in the NICU and we also hate in the NICU. It is one of those very difficult procedures to take babies off the unit, but the pictures it gives us allows us to be able to guide the care that we give these babies. So with this presentation from Dr. Weiss, he gives you some really great tips and tricks on how to read and analyze MRI. And he specifically focuses on HIE, but all of the principles he gives you can work for any neonatal MRI. So I hope that you'll enjoy this presentation. It was part of a workshop we did during the 2021 Virtual One conference, and Dr. Weiss was so gracious to be with us, and we had a really great Q&A at the end of this as well. If you have been enjoying our series, definitely go ahead and click that subscribe button, hit that notification bell so that you never miss a new video from us. If you'd like to get some of the slides and other resources related to this series, go ahead and click the link in the show notes below or scan the QR code somewhere on this screen. But without further ado, please enjoy this presentation from Dr. Mike Weiss.
Dr. Weiss is our next presenter, and Dr. Weiss has an interest in neonatal neurology and has actively performed research in this area, both basic science and clinical, for the last 20 years. Research interests include new imaging modalities, biomarkers for predicting outcomes in neonates with HIE, and adjunct neuroprotective therapies for neonates with HIE. He's passionate about improving outcomes in neonates with brain injuries. And as we've talked about already, he helped form the FN3 network to improve outcomes for babies with brain injuries throughout the state of Florida. And we've already gotten to hear some of his wisdom this morning, and he's going to share more with us now.
That was a very kind introduction. I appreciate it, Lauren. I'd like to thank the organizing committee for the kind invitation to speak today. It's a great personal honor for me to be included, given the outstanding credentials of my fellow speakers. And so the title of my talk is Behind the Magnet, the Secret World of MRI. Now, my talk was originally several years ago supposed to be in Nashville, so I wanted to keep a music theme for today. And interpreting an MRI can often be like music. A lot of people that are non-musicians look at music as being a very strange language, but once you learn just a little bit about music, it becomes like a second language, a skill that you can acquire very quickly. And so really MRI is the same way. Today I'm going to show you some basic principles that allow you to begin to interpret MRIs at the bedside. And what I'll do is take you behind the music. So I have no relevant financial relationships to disclose or conflicts of interest to resolve. I will not discuss any unapproved or off-label experimental or investigational use of a product, drug, or device. My only disclaimer is that I am not a neuroradiologist. I'm a neonatologist. And really, I'm going to approach this presentation from that of a neonatologist, just a bedside clinician, and provide you with some very simple steps to interpret MRI, some K.I.S.S steps, keep it simple, silly, steps that you can work through at the bedside and really begin to feel very comfortable about interpreting MRIs. And as I tell all the families, I have about a high school level of education in interpreting MRIs. The neuroradiologists really are the PhD folks. So they're really the folks that are very skilled at reading these. But again, I'll provide you with some rules today, or simple steps to allow you to feel much more comfortable looking at these studies. Here's my learning objectives. I'll discuss how the pathophysiology of HIE affects the ideal timing of neuroimaging and the expected findings, describe the basic principles of how MRI images are created, list at least 2 imaging sequences on the MRI that can be used to identify the extent and location of brain injury caused by hypoxic ischemic encephalopathy. Describe 2 features seen on MR images that are associated with the presence of brain injury following HIE. Now here's a outline of how I plan to obtain those objectives. I'll begin with a brief section about the pathophysiology of HIE, and really an understanding of the pathophysiology of HIE provides a foundation to really comprehend the various times that we obtain MRIs and the strengths and weaknesses of these time points in relationship to the pathophysiology. Then I'll go over some MRI basics. I'll have a section on the normal brain MRI. Then I'll show you the findings on the MRI with hypoxic ischemic encephalopathy, I have a series of cases that we can work through together to tie a lot of the principles that we've discussed throughout the talk. And then I'll end with a suggested schema for neuromonitoring and neuroimaging during hypothermia as really we progress into the future. And I'll begin with the pathophysiology. And the easiest way to tell you about the pathophysiology, especially giving this lecture from the great state of Florida, is to take you on a fantastic voyage into the brain of a 38-week fetus. And as we begin our voyage, we find a brain in a state of happy homeostasis. It is receiving adequate cerebral blood flow, which is delivering enough oxygen and glucose to meet cellular energy demands. Suddenly something happens like a placental abruption. Our fetal cardiac output drops, which decreases the delivery of both oxygen and glucose to the brain, producing hypoxia ischemia. Suddenly, our state of happy homeostasis is disrupted. At a cellular level, the lack of oxygen causes the cells to become anaerobic, which results in a decrease in ATP production. Now, ATP is really the cellular energy currency. It's responsible for driving the day-to-day housekeeping activities of the cell. Without it, the cells go broke and fall into a state of disrepair. Hypoxia ischemia also has a profound effect on the neurosynaptic junction, and it unleashes a variety of other pathophysiologic cascades. And I wanted to show you these other cascades in relationship to what we see clinically at the bedside to make the pathophysiology more applicable to taking care of patients. So this is our hypoxic ischemic insult. We have a decrease in glucose and oxygen delivery and a decrease in ATP production. Now, really, the hypoxic ischemic event may be due to something like a placental abruption. And it's important to note that only in roughly about 30 to 40% of the cases do we have a true sentinel event, such as a placental abruption, and we know the exact timing of the hypoxic ischemic event. So for the purposes of this pathophysiologic slide, we'll assume that we know the exact timing of the insult. Then we have a period of reperfusion, and this is when we're actively resuscitating the child. That resuscitation occurs in the delivery room and may continue when we get the child back to the NICU. But for arbitrary reasons, I've chosen 30 minutes to represent the resuscitation of this particular patient. Then we enter the first phase after our hypoxic ischemic injury, and that's called the latent phase. And this is a period of cell death and the activation of multiple programmed cell death pathways, which can lead to either apoptosis or necrosis. And the hypoxia ischemia also releases a variety of pathophysiologic cascades, such as excitotoxicity from increased glutamate release. There's an inflammatory response, and there's oxidative stress. Now, during the secondary phase, which begins about 6 to 12 hours, and notice that's 6 hours, because what we're trying to do with cooling is start the cooling therapy and prevent this progression into the secondary phase of injury. And really, what we see at a cellular level is we see secondary mitochondrial failure. And what we see clinically at the bedside that's classically a hallmark of the secondary phase is seizure activity. And then we have continued excitotoxicity, inflammation, and oxidative stress. And the secondary phase can last up to 3 days. Then we go into a tertiary phase, which is a period of late cell death. So there's a period of remodeling in the brain where there's removal of dead tissue. There's astrogliosis or scar formation, and there's actually attempts by the brain to repair itself with the production of new stem cells. However, these new cells do not last for very long. Even though they go to the areas of injury, they don't tend to survive and recolonize these areas. Now, this is a flow diagram which summarizes systemic supportive care, and systemic supportive care is still the foundation of what we do as neurointensivists in the NICU. And this was done with a fellow in my lab at the time, K.I.S.S, and myself, and it's really broken down by a systems-oriented approach. And I don't want to go over all these things, but I want to give you some general overriding principles. So our first goal as neurointensivists is to restore adequate cerebral blood flow. And so we want to make sure that these neonates are adequately resuscitated. Like I said, the resuscitation may extend from the delivery room into the neonatal intensive care unit. And the second overriding principle is we want to protect the brain from secondary injury, which can occur due to multi-organ dysfunction. And that's what this flow diagram essentially summarizes. So from a respiratory standpoint, we want to really maintain normal CO2s because CO2 affects cerebral perfusion. We want to maintain normal blood pressures because if we have a blood pressure that's too low, we could have a secondary decrease in oxygen and glucose delivery to the brain, producing hypoxia ischemia. So we want to avoid hypotension. And usually, as a general rule, if you remember the rules of 40, if you have a CO2 and a mean arterial blood pressure around 40, you should have adequate cerebral perfusion. Now, there's many NICUs that are starting to measure or monitor cerebral oximetry in this patient population. And this allows you to individualize your therapy for those particular patients. Now, with the pathophysiology in mind, I wanted to talk about imaging windows for MRIs in relationship to the pathophysiology and how the pathophysiology and the timing of the MRIs are interrelated. So this is from the work of Terry Ender and her group. At the time, Terry was at WashU when this paper was done. And this is the mean diffusivity ratio. And this is the days after birth. And the red line represents a period of time before hypothermia. So these babies only received systemic supportive care and normal thermia. And the black line represents babies that underwent therapeutic hypothermia. Now, what the authors were trying to do was really understand changes in this mean diffusivity ratio in the area of therapeutic hypothermia. When we're talking about the mean diffusivity ratio, what we're really referring to are these bright areas on the diffusion weighted images. Those ratios are really related to these areas. And so in the diffusion weighted images, bright areas represent areas of injury. And the lower this line goes, the more brightness we see. As this line starts to approach 1, that brightness goes away. And we call that pseudo-normalization because the injury is still there, but we just don't see it on this particular sequence. And as you can see, in the era of normal thermia, the mean diffusivity ratio peaked. So the optimal timing to do an MRI was about 48 to 72 hours. And we can see during the era of hypothermia, that peak is about the same, but it's extended a little bit longer. And then the period to pseudo is longer in kids who underwent hypothermia compared to normal thermic babies. So it takes longer in the hypothermia group for this whiteness or these areas of injury that are showing up on the diffusion weighted images to completely go away. Now, this bottom panel represents neonates who underwent hypothermia, but this is a group with a moderate HIE, and this is a group with severe HIE. And we can see that the mean diffusivity ratio is lower in the neonates with severe HIE compared to the moderates, and the time to pseudo-normalization is longer in the neonates with more severe HIE. So what does this mean clinically at the bedside? If we went in and imaged a baby within the first couple of hours of life, we can see that the mean diffusivity ratio hasn't decreased that much. And so we may not see these bright areas when there's actually injury there. So that's why it's important to pick an optimal time period. On the other hand, if we image a baby at 14 days, the mean diffusivity ratio may have pseudo-normalized and we won't see any injury on the diffusion weighted images. Now there's multiple images on the MRI and we will see injury on some of the other sequences that we get. But this really shows the interrelationship between the pathophysiology and the timing of when we obtain an MRI. Now let's talk about MRI basics. And here's our first musician, Johnny Cash. We can't talk about Nashville without talking about Johnny Cash. Now, MRIs can be very scary because of the physics involved. And I really want to demystify that. We're going to talk about the MRI basics. Essentially, what we do is we put the patient in a big magnet. And this MRI has a huge magnet, and then it has these radio frequency coils, which are next to the magnet. So now what's happening in that MRI scanner is each of the cells have atoms. The atoms spin in random directions like tops around their individual magnetic fields. In a magnetic field, such as an MRI, the atoms line up either north or south. About half the atoms go each way, but there are a few unmatched atoms, represented by green in this illustration. So what we do is we give a radio frequency pulse, that radio frequency transmitter that was next to the magnet, and the unmatched atoms spin the other way, so they rotate. And then what we do is we stop the radio frequency, we turn it off, and the extra atoms return to the normal position. And when they return to their normal position, they emit energy. And that energy sends a signal to the computer. The computer uses a mathematical formula to convert the signal into an image. And that's essentially what we interpret on the MRI is these various shades of gray because of these atoms flipping and going back to a normal pattern. So the first thing in our keep it simple, silly rule is to determine the sequences that we have on our MRI. Now there's different sequences at every hospital and with different brands of scanners. However, there's a core set that you're going to see, in particular in neonates. And those sequences are a T1, a T2, a diffusion weighted image, or DWI, an ADC map, or absolute diffusion coefficient map, and then the last one is a susceptibility weighted image. So that's the first thing, is to understand the sequences that you're getting on your particular MRI. Now, our second checklist, or keep it simple, silly rule, is to identify the sequence. And so how are we going to do that? On T1, water is dark, fat is bright. So usually what we do is we look for the lateral ventricles and we look at the cerebral spinal fluid. If the cerebral spinal fluid is dark, we know that's a T1 weighted image. Now on T2, it's actually the opposite of the T1s. Water is bright and fat is dark. On the diffusion weighted images, this really looks for water flux. And really after injury, there's a problem with water flux. And this really represents an early sign of injury. And these appear as bright areas on the MRI. The next sequence is the absolute diffusion coefficient map. And I'll show you examples of this, but it almost looks like a pixelated image. So that's how you're going to identify it. And it's really used to confirm the diffusion weighted imaging findings. We want to make sure what we're finding on the diffusion weighted images is an artifact. So the areas of brightness on the diffusion weighted images should match dark areas on the ADC map. And that really confirms areas of injury. The susceptibility weighted images look for blood. Remember, blood contains iron. We're putting these neonates in a very powerful magnet, so it's very sensitive at picking up blood. Now, one of the resources I would highly recommend, and it's free, is MRI of the Neonatal Brain. This is by Mary A. Rutherford, and I provided you with the link. And this is a very good online textbook that really goes through the basics of MRI across different gestational ages. It also covers things like hypoxic ischemic encephalopathy, findings with various metabolic disorders, findings with various infections, bilirubin encephalopathy. So it's a very good online resource. So now it's test time. So if this was a T1 weighted image, what would this be? And the answer would be water. Now, if it was a T2 weighted image, what would the black areas be? It would be the opposite of the T1. So these are going to be areas of fat, or myelination in the brain. Now, this is a bright area. So what would this be on T1? It would be fat, or myelin in the brain. On T2, it would be the opposite. So this would be water. Now I want to progress into the normal brain MRI. Show you some normal images. So this is a T1 image, and this is a T2 image, and we're up around the cortex. And so what we can see is higher T1 signals in the periorlandic cortex and the corticospinal white matter tracts. And the reason for these areas is they're the areas that are myelinated in term neonates. And neonates are in the process of myelinating their brains. And we have certain areas that should be myelinated. It's very important to understand the normal myelination pattern so we can distinguish normal myelination from brightness on T1 weighted images associated with injury after hypoxic ischemic encephalopathy. This is a T2 weighted image, and as you can see, there's darker signals in the myelinated white matter. So as we move back, we can see that it's darker here compared to here. Remember, on the T2 weighted images, fat is going to be dark. And so that's why we see the differences between these two scans with the myelination. Again, a T1 and a T2 weighted image, we see a high T1 signal in the posterior limb of the internal capsule, and we see a low T2 signal in the posterior limb. So they're actually the opposite. And this is the posterior limb of the internal capsule. It should be one of the brightest structures in the midbrain. And again, this is the posterior limb of the internal capsule. It is myelinated, so it's dark on T2. It's bright on T1. And just like we looked at before, we can see the lateral ventricles. And this is filled with cerebral spinal fluid, which is dark on T1 and bright on T2. Now, we can also see high signal in the globus pallidus and dorsal putamen and ventrolateral thalmi. So this is going to be up in the globus pallidus and putamen. This is very important because in kids with mild hypoxic ischemic encephalopathy, sometimes this brightness extends out further and it's a little brighter than what the neuroradiologists expect. And so oftentimes they hedge their bets and say this could be a normal myelination pattern, or it could be consistent with mild hypoxic ischemic injury. And so that's really why you're seeing that on the reports sometimes, and they're hedging their bets because they just have a very difficult time differentiating that. And again, this is going to be on the T2 weighted images, which are going to be the opposite. Now let's talk about the MRI and hypoxic ischemic encephalopathy. So now, what's our checklist for HIE? Now that we know the sequences, we know a little bit about how to distinguish the sequences, we know a little bit about what the normal brain looks like. What should our K.I.S.S checklist look like for neonates with HIE? On the T1 weighted images, we want to look for bright signals from increased intracellular calcium. And these appear as very bright areas. On the T2 weighted images, we want to look for blurring of the gray-white differentiation from increased intracellular water in the cortex. We want to look for bright signals in the white matter. And the diffusion weighted images, which is the image we rely on primarily the most when we do early imaging right after therapeutic hypothermia, we want to look for restricted diffusion, which are going to be those bright areas. And on MR spectroscopy, we want to look for lactate peaks, which are a biomarker of injury. The brain, just like other organs, when it lacks oxygen, it becomes anaerobic and produces lactate. So when we do MR spectroscopy, we see an increase in the concentration of lactate, or an increased lactate peak. The other thing we look for in spectroscopy is a decrease in a metabolite called N-acetyl aspartate. N-acetyl aspartate is a neuronal marker. So the pattern we normally see is a decrease in N-acetyl aspartate and an increase in lactate. And that really tells us that there's been injury to whatever area. We put a little voxel or box over and ask the MRI machine to do spectroscopy over. So here's some images of a neonate with injury to the basal ganglia and the thalamus. Okay, so let's go through our K.I.S.S rules and determine what sequences we have. And so if we look here, what sequence is this going to be? The CSF is dark, so this would be a T1 weighted image. If we move over to the corresponding sequence, what sequence would this be? The CSF is bright. So this is a T2 weighted image. This is what a diffusion weighted image looks like. Again, it almost looks a little pixelated, and it's not as sharp as the T1 and T2 weighted images. And this is the ADC map, and you can see that this is very pixelated. I usually look at the edges, and when I start to see these pixels, I know right away I'm dealing with an ADC map. So in this, we can see that there's too much brightness in the basal ganglia, and we see restricted diffusion or bright areas in the thalamus. Now, we should see on the ADC map corresponding dark areas, and that really confirms that there's true injury in these regions. And you can see how those areas correspond identically. So that really tells us that there's definitively injury to the thalamus. Now, this is a scan at 47 days. We see high T1 signal in the basal ganglia and the thalamus from intracellular calcium shifts. And again, there's going to be these very bright areas. How about a baby with total injury to the brain? Again, let's use our simple rules. So what sequence is this? CSF is dark, so it's a T1 weighted image. CSF is bright, so this is a T2 weighted images. These images aren't as clear, but the edge doesn't have the pixelation, so they're diffusion weighted images. And we can see the pixelation along the edges. So this is an ADC map. And you can see that there's diffuse, restricted diffusion throughout this brain. And so this is injury to the entire cortex and the subcortical white matter. And we can see one of the images that corresponds to the diffusion weighted images with the ADC map. And again, the dark areas match the areas of restricted diffusion. So we know that injury's true. And if we wanted to, we could actually match all these with their corresponding ADC maps. Now, I wanted to shift gears and talk a little bit about MRI during hypothermia. So the first thing is, can you do it? And the answer is yes. And the second point is that why would you do it? And really, it's to help you make clinical decision making. If you're making a decision about potentially withdrawing support, the MRI can help give the family additional information to allow them to make an informed decision. And there's really two methods to do an MRI during hypothermia. The first is to transport the neonate to the MRI itself and continue active hypothermia while in the scanner. And the second is to perform an MRI in the NICU with active hypothermia. So this would be an MRI machine that's actually located in the neonatal intensive care unit. And so the first example, I wanted to show you an MRI where we transported the baby down and continued active hypothermia at our facility. This was a term neonate born via emergent C-section for prolonged fetal bradycardia and placental abruption. At the delivery, the baby was limp, cyanotic, and apneic. Resuscitation required CPR, intubation, and 5 doses of epinephrine. The APGAR scores were 0, 0, 0, and 3 at 1, 5, 10, and 15 minutes respectively. The initial venous blood gas was 6.5 with a PCO2 of 97.5, an undetectable PaO2 and a base deficit greater than -30. This baby was actually born at a smaller level 2 facility, and following stabilization, the baby was transported to our facility, and our transport team does use active hypothermia, so it was started prior to arrival at our facility, so it was started during the actual transport. Upon admission to the NICU, the neonate's neurologic state was consistent with a SARNOT 3. The exam did not improve during the entire period of cooling. There was essentially a flat EEG. And during the rewarming process, we had a very difficult time, and we had to stop the rewarming after about a degree increase because the baby started having intractable seizures. And so the family really wanted more information and deciding whether or not they wanted to withdraw support. So we decided to take the baby down for an MRI. And this shows the device that we use, the critical, in the control room. It is not MR compatible, so it has to stay in the control room. And this shows the tubing. This is the normal critical tubing. This is an 18-foot long tubing that goes through a hole in the wall and then into the MRI scanner. And you'll notice that unlike the normal tubing, it is insulated to keep the temperature of the water the same because it has to travel a greater length. And this shows our staff hooking the critical up in the MRI scanner, and you can see the coil over the baby's head. And I apologize, these pictures are a little bit pixelated because the window in our MRI facility has a metal mesh or some type of mesh. This shows the neonate in the scanner. You can see the tubing extending in and up to the baby, and the baby's laying on the wrap. Now, I wanted to talk a little bit about how this is done with the critical, because we have to modify our normal technique when we do this in the MRI facility. So the way the critical normally works is we set a desired temperature. It circulates water. It then measures the core and surface temperature from the neonate and makes any adjustments to the water temperature in order to maintain the core temperature within the targeted zone that we've dialed into the machine. And so here's the display. So this is the set point, or our desired temperature. This is the reading of the core temperature, and this is the surface temperature. So it's continually getting this feedback loop, a closed feedback loop, and making adjustments. Now, with the neonate in the scanner, the surface probe and the rectal probe, which insert into the critical, are not MRI compatible. So in this scenario, we have the water that circulates, and then we have a core temperature probe, which is MR compatible, going to a separate device. That device does not hook into the critical. So what we have to do is manually enter the core temperature. And the way we do that is with the simulator. So we would turn the simulator, whatever core temperature the device is reading about every 3 to 5 minutes, we would match that core temperature in the machine by turning this dial. And then the critical would make any adjustments if the core temperature was either below or above the targeted temperature, and it would either cool or heat the water to bring the baby within that desired temperature range. So these are some of the images that we obtained. Again, if we use our K.I.S.S rules, dark CSF, so T1, bright CSF, T2, again, almost like a not clear image. So this is the diffusion weighted image, and this is very pixelated along the edges. So this is our ADC map. I just really want to highlight the diffusion weighted images. There was pretty much restricted diffusion of the entire brain. And we can see on the ADC map that this matches with darkness across the whole brain. So we went back to this family and presented the information from the scan. They decided to withdraw support, so we warmed the baby up to a normal temperature, and then at that point withdrew support. Now, the second method that we can obtain an MRI is using a scanner in the NICU. And this shows the Embrace. It's a 1 Tesla magnet. And I failed to mention that the field strength that we scanned at our institute was 3 Tesla. And it's completely encased. And the important thing about that is all the intensive care equipment can actually go into the room with the scanner. And we see the video of the baby in the scanner. This device has a reasonably small footprint, but it's very heavy. And these are slides courtesy of Terry Ender. It shows them loading the MRI scanner at Boston Children's, and they actually had to lower this through the roof of their NICU to get their scanner into place. So we can see the crane on the street, and then we can see the device being lowered through their ceiling. Now, Dr. Ender was kind enough to share a case with me, and this was a neonate who was undergoing hypothermia, was also on an oscillator, nitric oxide, and 8 infusions. And the question was whether or not to continue support of this child. And so they were actually able to use their scanner in their NICU to scan the child. They were very concerned about the neurologic exam, but when they scanned the child, we can see on the diffusion weighted images that there's only small areas of restricted diffusion. And this was actually done at 4 days right after rewarming, and this is 14 days. And again, this is going to be a T1 weighted image because of the dark CSF, and we can see some of these areas up in the cortex. So very minimal injury. So based on the day of life 4 scan, they spoke with the family and the decision was made to continue with full support. And this is the child at 9 months with a normal development. So again, just shows the utility of these MRI scanners to make clinical decisions. Now, I wanted to show you a few cases, and I had to have some more Nashville groups. My son and I were traveling back from Nashville a number of years ago, and we drove by Bonnaroo, which is out in Manchester, Tennessee, really out in the middle of nowhere. And we were actually listening to the broadcast, and this group came on. I had never heard them before, but they're based out of Nashville. A very good group, Nashville group. And then Jack White, who's a tremendous guitarist, originally from Detroit, but he makes his home now in Nashville, Tennessee. So now I wanted to show you a few cases, and we'll work through these together with the scans. So case 1 is a 38-week neonate. The mother reported decreased fetal movement for several hours. The amniotic fluid was foul smelling. There were non-reassuring fetal heart tones, which progressed to no fetal heart rate detected. The neonate required bag mask ventilation, initially intubation, CPR, and multiple rounds of epinephrine. The first heart rate wasn't detected until 12 minutes of age. Initial cord gas had a pH of 6.78 with a PCO2 of 102 and a base deficit of 18. The neuroexam showed a lethargic neonate with increased tone, decerebrate posturing, no reflexes, no suck. Pupils were dilated and fixed to light. So this baby had a SARNOT 3 exam, and it really didn't change throughout the course of hypothermia. The child also had a persistently elevated lactic acid, had a worsening respiratory status requiring high-frequency oscillator ventilation, INO, steroids, and surfactant. And then the big question that came up, was this baby an ECMO candidate? And we have a group approach where we talk to the pediatric surgeons. Our pediatric neurologists are involved. I usually involve another neonatologist, and we all go over the potential outcomes. We also involve the families, and in this particular case, the child was not an ECMO candidate. This shows the brain after rewarming, and this is going to be a diffusion weighted image. Again, notice how it's not very clear. There were also some blood products which appear as dark areas on the scan, but we can see that there's restricted diffusion throughout the brain. So extensive injury in the cortex and the subcortical white matter extended down into the basal ganglia. And the placental pathology came back positive for an infection. And I spent time with the placental pathologist doing some additional stains because we were trying to figure out what organism it was, because our blood cultures were negative, but I wanted some idea of the organism so we knew how long to treat the neonate and what antibiotics to use. And what this shows is the normal villus and the placenta. Now these are the gas exchange units in the placenta. And this shows a placenta with villitis or inflammation with a microabscesses containing mostly neutrophils and a case of congenital infection with listeria. And this is essentially what the placenta looked like from our patient. And they actually did some special stains and were actually able to see listeria within the placental tissue. Now, this is the MRI that was done at about 14 days of age. And you can see this is a T2 weighted image because water is going to be white on those image sequences. And you can see that there's really nothing left of the brain. The entire brain has been destroyed. The combination of infection and HIE is additive, and you can see the marked destruction in this particular case. So case number 2 is a 39-week gestation, a C-section after a failed vacuum extraction. APGARs were 0, 3, and 5 at 1, 5, and 10 minutes. The neonate met cooling criteria and underwent therapeutic hypothermia. These are our images that were obtained. These were obtained on day 6. And if we look, we have our T1, T2, and these are going to be our diffusion weighted images down here. So really we had these areas of restricted diffusion in the cortex and the subcortical white matter. And if we look, these are actually along vascular watershed areas. You may have heard that term a lot. So what is a vascular watershed area? Vascular watershed areas occur between vessels in the brain. This is the posterior cerebral artery, and this coloration represents its perfusion area. This is the middle cerebral artery, which perfuses a majority of the brain. And this is the anterior cerebral artery represented by this blue coloration. So whenever we have a drop in the fetal heart rate, there can be decreased perfusion to the brain. And really the areas that are affected the most are between the vascular zones. And so that's really in this particular case where we see the injury. It's between the area between the MCA and the PCA. And so these are considered watershed infarcts or watershed injury. So the next case is a 38-week gestation neonate who had meconium aspiration syndrome. APGAR scores were 1, 1, and 3 at 1, 5, and 10 minutes. The baby underwent therapeutic hypothermia, and we obtained these images upon rewarming. And again, this is our T1 weighted image, dark CSF, T2, bright CSF. These are all diffusion weighted images, and this is our ADC map. And as you can see, there's marked global hypoxic ischemic injury with restricted diffusion throughout the brain. If we look at our ADC map, it matches those areas. Had to end with a photo of guitars. My wife would tell you that this is what our house looks like. It's not quite that bad. I wish it was, but it's not quite that bad. And I'm definitely not allowed to hang any guitars on the wall. But now I wanted to just wrap all this up about talking about a suggested schema for both neuromonitoring and neuroimaging during hypothermia. So to tie in a lot of the principles that we've talked about with MRI, a lot of the neuromonitoring things that you may see at the bedside, and how we can really develop a schema in the future to treat these babies. Now I'm talking about the future, and I am getting older every year, and I'm starting to feel a little old, but I have to remember that Yoda was old, but even at an old age, he could still kick some butt. So let's start this section by taking a neonate who's 36 weeks or greater with a diagnosis of HIE. And then really the first thing that we should do that's always the foundation of care is systemic supportive care. We really need to stratify these babies based on their neurologic exam. We can use things like the amplitude integrated EEG, cerebral mixed saturations, biomarkers, looking at the cord gases, and then emerging biomarkers, which look at brain-specific proteins. And this is an area that I'm very interested in actively doing research. There's actually in particular, one called UCHL1 and another called GFAP. UCHL1 is a neuronal marker. GFAP, or glial fibrillary acidic protein, is a astrocytic marker. And in the adult world, they actually have a prototype device that looks just like an iStat. So when an adult comes into the ER with a mild traumatic brain injury, they can do a finger stick and measure some of these brain markers. And so this technology is going to eventually filter down to the bedside of neonates. And we're going to have a way to objectively measure, hopefully, the degree of injury and the timing of injury. Now, we can also use modeling, and this is actually looking at data from our group, and what this is a ROC curve, and that what ROC curves look at is the ability of the test to perform well. And so the larger area underneath these curves, the better, essentially the better the test. And this dotted line shows cerebral oximetry at 12 hours, and this box over here is 24 hours, and shows cerebral oximetry alone. Now, when we combine cerebral oximetry with some of the background patterns on the EEG, we can see the predictive value improves. And so I think as we move forward in the future, that we're really going to use a combination of things to model and have a scoring system at the bedside where we input the biomarkers, the cerebral oximeter, some of the background patterns on the EEG, and really objectively score these babies with HIE into different categories. So then when we have our babies, we can divide them into having mild, moderate, and severe. The kids with mild HIE, and a lot of NICUs have gone to low cord pH screening programs, including ours. We continually do serial exams in these babies for the first 6 hours of life if their cord pHs are low. But the babies with mild HIE, we would continue to monitor closely and maybe use the amplitude integrated EEG, the cerebral mixed saturations, and biomarkers, and pick out babies at risk for brain injury, and potentially an in-unit MRI could help us with that. Now we have to remember back to the earlier slides, if we image too early, we may get a false negative. So it may be a situation where the markers say that there could be injury. We start cooling if cooling's proven to be effective for kids with mild HIE, and then stop the cooling early, or if they don't have any injury, or continue it for the entire 72 hours. But the brain MRI may help us make those decisions. So some of these kids with mild HIE do evolve into a moderate encephalopathy, and those are the kids that we currently want to cool and not miss. The kids with mild HIE, currently the standard of care is supportive care. Again, there's trials looking at hypothermia in this patient population. The kids with moderate to severe HIE, between 0 to 24 hours, we'll stabilize them. Again, cool them, potentially add other pharmacologic agents. And we may have an objective system, hopefully with some of these biomarkers, to select the kids that would benefit from that. We want to continue to re-stratify these kids based on their neurologic exam, the amplitude, cerebral mix saturations, our biomarkers, hopefully brain specific. Consider doing an MRI with diffusion weighted imaging during cooling. And then we can divide these kids into moderate and severe. The moderate kids, we can continue cooling for 72 hours and continue our systemic supportive care. And the kids with severe encephalopathies, again, we can add other pharmacologic agents such as melatonin. And then we could consider stem cell therapy in these patients as well. So that's all I have. I've really enjoyed giving this talk, and I always like to end with a picture of my family at the beach. It's always a happy time at the beach. And this is my older son, Kobe, who actually played for the South Florida Bulls and was their kicker. So hopefully today I've jump-started your desire to kick into action, to really learn more about MRIs and to begin to feel comfortable to interpret these and actually look at the MRI images yourself at the bedside or while a physician's showing a parent. And hopefully you'll be very successful in doing that. Again, I thank you so much for listening to the presentation, and I'll be more than happy to answer any questions.
Thanks, Dr. Weiss, so much. Lauren, Dr. Weiss.
Oh, sure.
Yeah, thanks for a great talk. If you guys have questions, please type them into the chat. So far, some comments that have come through are people are saying they'll be watching this video over and over, that it's got such great content.
And I'm getting text messages too. People are like, this is so awesome.
Oh, thanks.
I personally loved all of the Big Bang Theory photos in there. It makes it fun.
Yeah, definitely love that show. Have that Sheldon side.
I did put into the chat the MRI neonatalbrain.com link in there in case anybody had missed that as Dr. Weiss was talking. So that's there. Jackie is asking, are you using esophageal probes in the units that are MRI compatible?
Yeah, and the one probe that we have is just a universal probe that's left down in the MRI suite. It was bought by anesthesia, and so the probe that we were using, we used it rectally, but it is MR compatible. So I'm sure there's an esophageal version, or people can use it via the esophagus. Just one of the things that we try to do is just there's so much equipment, and with the head coil and everything, I think the rectal probes just work a little bit easier, just for monitoring while they're in the scanner.
Would you point out what you are specifically looking at in the ADC images?
Yeah, sure. I had a few more things that I wanted to show you guys, and I'll definitely answer that question as well, because there was a few things that I mentioned on the talk that I didn't have time to show you. And a lot of times the scans have the sequence on it. So if you look down in the corner, they'll list those. And so this is a T2 weighted image, and this actually shows some blood. Now, corresponding, this is a susceptibility weighted image. I mentioned that in the talk, but I didn't actually show you an image. But this just shows how easy it is to see blood on the susceptibility weighted image. There's a small drop of blood right here, which may be very hard to pick up. But then when we see the corresponding susceptibility weighted image, we can see there's definitely a little punctate area there of hemorrhage. And so this was a premature baby. So this was probably just a little grade 1 IVH that occurred. But it just shows you how easy those are to pick up with the susceptibility weighted images. Again, the susceptibility weighted images, the way I really discern those is if you look at the brain, it all looks white. There's really no differentiation of the brain structures. And just these really dark areas are going to be blood. I also mentioned RES, and this shows a magnetic resonance spectroscopy. And what they do is they put a little box over the brain, and that little box is post-processed for all the metabolites that are in that box. So you can tell the tech to put that box wherever you want in the brain, and they'll look at the metabolites. So this is N-acetyl aspartate, and it's a neuronal marker. So with HIE, with injury, we have loss of neurons. So this actually goes down. So it decreases. And then the lactate peaks here about 1.2, 1.3 parts per million. And so it's going to go up over time. And so just like any cell in the body, when it becomes anaerobic, it makes lots of lactate. And so we'll see that pattern in the brain. The N-acetyl aspartate goes down and the lactate peak goes up. So sometimes that helps us if we have a baby, like I was mentioned earlier, that we're concerned about injury to the basal ganglia, but we don't know for sure. And so that's what we usually do, is put that box over the basal ganglia to help us decide. This is showing the basal ganglia that's been mentioned several times. Sometimes this brightness just extends a little bit too far. And this was actually a clinical patient that we saw over the last week. And we were trying to debate whether or not there was injury there or not. So this is a T1 weighted sequence, and about half the neuroradiologists thought there may be some subtle injury in the basal ganglia, and half of them thought it was normal. So it just shows you how open to interpretation sometimes these scans can be. And oftentimes the neuroradiologists hedge their bets and they say there could be injury to this area. Again, blood shows up sometimes very easily on the MRI scanner. If you look, this is a T1 weighted image. This just shows a little bit of blood. This is a subdural. It's a lot of times that we see from birth, just to show you a little different example. And this one I want to throw out to the crowd, and I'm definitely going to answer that question about the ADC map. So this is a baby with a big head circumference. And if you guys want to look at this for the folks that are on, and feel free to either type in the chat or turn on your camera. And so this baby had an enlarged head at birth, and we got this scan. And if you want to look at, you can see it's a T2 weighted signal. So if folks want to chime in what they think all that is. And again, this just shows that those K.I.S.S rules can be used outside HIE. So you can use it to interpret any scan that comes across. What do folks think it is? What is bright on T2? And so what do you guys think this is? If you know it has a big head and there's a lot of water.
Yeah, people are saying CSF and hydrocephalus.
That's right, 100% correct. And so just by knowing those few little principles, you can use this for multiple things. And this just is another example. It shows the next premature baby. And what we're seeing here is enlargement of the lateral ventricles. Again, it's a T2 weighted signal. We can see the brain's also very smooth. And you can actually see these are blood products in the brain. So this is a baby that had post-hemorrhagic hydrocephalus. So just to give you some other examples, just some other cases besides HIE that you can potentially use the exact same principles on any scan. So you know that's water right away, and you know that's probably CSF, and those are the ventricles and they're enlarged. So that should help. Again, this is another example of that blood products on the susceptibility weighted image, and we see how easy it is to pick up. Also notice that it halos around it. So the actual amount of blood is this amount, but since the susceptibility weighted image is really good at picking this up, it almost halos around the area. So it makes it a little bigger. We call that blooming. And so it lets us know that there's blood there, but the actual bleed may be smaller. And so that's what the T2 is actually showing.
Dr. Weiss, on the susceptibility, does it also help you to time that hemorrhage?
Really, you're going to look on the T1 and T2 weighted images for that. And there's a progression that the blood products take over time. So they're going to appear bright on certain images during the acute phase, during the subacute phase. And really, you're looking at the T1 and T2 weighted images. It's going to evolve over time. And so there's scales that are for that. And they'll tell you this bleed was within 1 to 2 days or occurred within a week. So it helps you time it within a couple days. It doesn't tell you the exact time, but it helps you.
Great.
And then this was a question that was asked on the ADC map, and I'll show some from the presentation as well. But this is the ADC map. And what we're looking on the ADC map is the dark areas. The dark areas. And again, you can see how pixelated this is. And we can see these dark areas on the ADC map. These are small punctate areas in the subcortical white matter. This is a corresponding T2, and we can actually see the same areas on the T2 weighted images, but you can see how hard they are to pick out, but they're very easy to pick out on the ADC map. And that's why you want to look at all the sequences, but the ADC really helps you a lot during that acute period. And I can bring up my talk and just show you the ADC and map, show you the match with the diffusion weighted to answer that question that was asked.
While you're doing that, I'll say one time, I don't know when it was, I was trying to explain all these different sequences to somebody, and I mentioned it's like you take a picture on Instagram and you have that original image, and then you can apply all those different filters, and that in some way thinking about the sequences is just like applying Instagram filters. It's the same brain, the same injury, but different things make certain things pop and others make things go away. So I don't know if that's a fair analogy, but it's helped me in my mind try to understand why we use some sequences for some things and sometimes we don't.
Yeah, no, it's a great way to think about it. And I think the important thing to remember is that the filters maybe change a little bit early on and a little bit later. So early on, you definitely have early on you have the diffusion weighted and the ADC maps. And then later on, you're going to have the T1 and T2 weighted images once it pseudonormalizes. But that's a great way to think about it, Kathy. That's a great way. But this goes back to the exact question that was asked. So what we want to look for in the diffusion weighted is these bright areas. And then what we want to make sure is that's not artifact, that it's not something called T2 shine through. And so we want to make sure that this injury is real and it's not an artifact. And the way we do that is we look, and you can actually link these sequences and you can see the exact areas of the brain that are bright or dark on the ADC map. And so that really confirms that there's definitely injury there. And so that's why you use those two together to really say, aha, these bright areas are dark and these dark areas are bright. We definitely have injury there.
And if it was an artifact, then you may not see those corresponding black areas. And that's when you would say, oh, okay. So you use it as a confirmatory.
That's right. That's right. That's right. Yeah.
Does that help, Liz? Or do you want to unmute? Let's see if she chats in.
No, that was great. That's exactly what I wanted to see, exactly the areas you're looking at.
Yeah, and they always match. And a lot of like we use Visage, you can lock the images even though they're two different sequences. So when you scroll through, the cuts are matched. And that way you can see them side by side as you go up and down and are able to really appreciate the matching. And so that's the neuroradiologists go through it at light speed. I still have to scroll through very slowly, but you will see the areas match.
Thank you very much.
Sure. No, thanks for the question.
We have another question. Katie's asking, is there an HIE staging grid for MRI findings similar to the way we have IVH grading?
Yeah, it's a great question. And so there are scoring systems for MRIs, and different centers use different scoring systems, and folks have matched those with outcomes. So there's the Barkovich scoring system that was developed at UC San Francisco. The National Institute of Child Health and Development also developed a scoring system. There's one that's used in England. So a lot of different scoring systems are used when the MRIs are obtained, and they just look at injury to the various areas of the brain, and they basically give a numeric value for anywhere from 0 to some areas it's 4, some areas it's 5, and the NICHD, you can actually add up some of those areas, or the new Barkovich, and so you come up with different stagings, and those have been shown to correlate with outcomes. And so the NICHD has correlated them up to 6 to 7 years of age.
Questions? Everybody who chimed in the chat got your hydrocephalus correct there.
Cool.
Earlier.
And again, that just shows that the same simple principles you can use for any read of any child. So a term corrected, if your center does them, any premature baby that goes down, it's the same kind of principles.
Dr. Weiss, it's Jane. I have a question.
Sure.
In your experience, how often do you see the reliability between like how you saw a baby present to their MRI findings to them at developmental follow-up? Like, does it really work out in the math that way, or are you often surprised by, gosh, that didn't look anything like what I thought that kid was going to look like?
Yeah, and it's a great question. And some of the things I struggle with are just when you show the parents the MRIs, and we know from talking to parents and hearing from Hope for HIE and some of these other organizations, that's such a big day for the parents. They call it MRI day. And I think there's so much involved in the outcomes. And so what I tell the parents is this is basically what the MRI shows. This is what kids do or have been studied, and this is what they've done in the study, but I can't tell you for sure that's what your child's going to look like at 24 months or 6 to 7 years, because I think there's so much plasticity involved. So yeah, there are those kids that we see MRIs that have injury, and we expected a devastated child at the clinic visit, and they're doing much better than we expected. And again, the parents are going to OT frequently. They're doing all the things that they can do to optimize the outcome. So I think there's so many dynamic factors that go on. That's why I think outcome prediction is really hard, because the neonatal brain has that ability to have synaptic plasticity and to compensate for some of these areas of injury, especially if it's unilateral.
I know I find that really challenging in the NICU, even when you talk about intraventricular hemorrhage. Like, you hate to paint, you don't want to make it self-fulfilling and tell a parent a grade 4 and this is it's doom and gloom, and then they believe that and they don't do the nature versus nurture kind of a thing. I feel like that's the most challenging thing in NICU is what do we do with the science to give a realistic picture? But because the baby brain is so amazing, in an adult, we pretty much know what we're going to get. But these babies are just incredible.
Yeah, I agree with you. It's tough to counsel parents. And what I always tell the families is I want to be realistic with you, but I also don't want to take away all your hope. I give them percentages. I show them similar examples from either the literature or what we've experienced at our center, and their percentages. And I say at the end of the day, your child's not a percentage. They're going to have deficits or not have deficits. And I've been surprised with the kids coming back to our follow-up clinic, how well they're doing. And a lot of these families are incredibly engaged, and they do all the follow-up appointments. They're doing things at home, and even the premature parents. And so we've seen some amazing things. Of course, we have bad outcomes too, like anyone else, but yeah, a lot of times we're pleasantly surprised at how well the kids are doing. And a lot of times your definition as a physician of how well the child's doing and the parent's definition are very different. And so I've had devastated kids come in the clinic, and they are excited to show me videos of the child watching TV, and they feel like interacting with them, and they just have a lot of joy. And I watch all the videos and I see all the things. And once they point it out, I see a lot of the things that they're talking about. So I think parental expectations also play into that pretty tremendously.
Yeah, that's a perfect answer. And like you said, I've learned so much from being part of Hope for HIE in what parents love. They love their kids. They don't, it's incredible. The journey that they're on is so different than ours. And what we would be satisfied with as having pretty normal kids, they're, like you said, every little thing for them is a joy, and they've embraced it, and they wouldn't change anything. And I always feel so bad when I don't have a kid with a good head, but they're really, it's okay. Imperfect is okay in the world.
Yeah, and a lot of things we've gone away from at the follow-up clinic, showing them what the kids can't do and really focusing in on what they can do. Obviously, we want them to understand what goals that we're trying to reach, but also really highlight what the kids can do. I've seen a real shift in that, and I've heard numerous lectures and talking to the parental organizations. We've tried to have that shift in philosophy when the families come, to really focus in on a lot of the great things the kids are doing. And then we talk about challenges. How can we overcome some of these other challenges and help them?
And this is my last question. How soon are we going to get that nifty device that you just get? Yeah, I'd like that pretty quick, please, Dr. Weiss. Yeah.
We're going to have to do some fundraising.
Oh my gosh, that would be amazing. Like a glucometer, right? It just guides you in the right direction. But do you think we'll see that in the next 10 or 20 years?
Yeah, I do. And Jane, just in our state, there's all these state regulations. And so that hurdle has been jumped across, because Wolfson's in Jacksonville is expecting delivery of their magnet, I think soon. I think Kathy can probably tell me more details than that. But so a lot of the regulatory things are fading away. So I think you are going to start seeing this in the next 5 years in the state of Florida and throughout the country, is these in the NICU magnets, because you don't have to take the kids down. A lot of times our kids are getting scanned in the middle of the night. It gives you flexibility with the timing of the scans, keeping the kids warm. A lot of things that we have to rely on the MRI facility to do, we can really control in our NICUs.
Thank you so much, Dr. Weiss, for sharing all of this with us today.
Sure. No, thank you guys.
Well, I don't know about you, but that presentation was so good. I loved hearing all of the practical tips and the great discussion that we had at the end about how to use MRI and how to read it and the future of this technology. So I really appreciate Dr. Weiss, and for all of our moderators who were there at the Virtual One conference in 2021. It's so fun to be able to bring these presentations back to you week after week and help you to care for babies better. Without your support, we couldn't continue to do this. So thank you so much for helping us by hitting that like and subscribe button, and definitely hit that notification bell. If you haven't already, go ahead and scan the QR code here on the screen or click the link in the show notes below. You'll be taken to a page where you enter your email address and you'll be given access to our slides and other resources. So thank you for your support. Thanks for watching us, and definitely stay tuned. We always have new videos coming out every Monday at 11. Okay, see you next time. Bye.